Good evening, senior teachers, my dear friends. First of all, I thank Dr. Prathapan for giving me this opportunity to present a topic, anatomy of pancreas, a surgeon's perspective. So, God has put the pancreas in the back because he did not want the surgeons messing with it. This is by Harold Ellis. So the pancreas has a critical anatomic location. As everybody knows, it is located between major vascular structures, and surgery happens to be a very difficult one. So until 20th century, most of the surgeons are not willing to take the risk of doing surgery on pancreas. But by the introduction of newer and newer imaging modalities and other methods of hemostasis and the recent types of electrosurgical equipments, most of the pancreatic tumors are resected now with good result. So if you go back to the history of pancreatic anatomy, it was considered as the hermit organ by surgeons of 20th century because the surgery of pancreas was a rarity. Nobody was there to perform operations upon it. First description of pancreas you can see in 300 BC by Herophilus of Shackleton. The Rufus of Ephesus actually coined the term pancreas. Basically, pancreas means all flesh. It's a Greek word. And the definition of pancreatic anatomy was first attempted by Andreas Vesalius and Kozhikode. And the various ductal systems were demonstrated by Wilson, Santorini, and the ampulla of Vater and sphincter were demonstrated by Abraham Vater and Kozhikode Oddi. So, if you see the original article by the Vesalius or Kozhikode, you can see the picture of pancreas with the ducts on either side of going as arborizing pattern on either side. The right picture shows the original imprint on copper by Wilson. It is available in the museum now. So the Kozhikode Oddi first described the Sphincter of Oddi, which is later found to have 4 parts. So the development of pancreas, as you all know, pancreas developed during the 4th week of embryonic period as ventral and dorsal outpouchings. And this is actually representing the junction of foregut and midgut. And ventral bud is also the primordial for liver and biliary system. So the ventral part of pancreas has close relation with the hepatobiliary system. The rotation of stomach creates the C loop, and the ventral bud moves dorsally and lies beneath and behind the dorsal pancreas. So if you see in open abdomen, the ventral part lies down. Actually, developmentally, it has to be on the upper part, but because of the rotation, it comes and lies in the lower part. The ventral bud becomes the uncinate process and the lower part of head of pancreas, and rest of the pancreas develops from the dorsal bud. And these two buds fuse and their ducts unite and form the ventral and dorsal duct, and finally they enter into the duodenum as major papilla and minor papilla. So histologically one can differentiate the ventral and dorsal pancreas because ventral pancreas is composed of smaller and more tightly packed lobules with pancreatic polypeptide rich islets, whereas the dorsal pancreas is composed of larger lobule with pancreatic polypeptide poor islets. And immunohistochemistry for pancreatic polypeptide actually helps to differentiate these two parts of development. So this is one which was mentioning the enlargement of the bursa omendalis or the omental bursa. You can see the pancreas has got some rotation at the junction between the head and the neck of pancreas. So if you see in actual human body, you can see pancreas has some rotation and the right part becomes the anterior. And if you just twist the pancreas up, you can see the vessels lying in close relations. So that area of pancreas is known as the auricle or the ear. And that part is very important because these are the areas where the vessels enter the pancreas. And if you try to dissect that area, if you don't know the anatomy properly, they can have bleeding. So this is the rotation of the rest of the duodenum and proximal part of jejunum during the embryonic development. So you can see the duodenum. Actually, the part of mesoduodenum on the posterior part lies on the anterior part of the jejunal mesentery. So that is why during dissection of the ligament of Treitz area and dissection of the proximal jejunum, you have alteration in the vascular supply. We see for the duodenum, the vessels will be on the other side and the jejunum vessels will be on the lower side. So if you know the development of pancreas, there are many congenital abnormalities and anatomical variants described. They include pancreas divisum, annular pancreas, dorsal pancreas agenesis, heterotopic pancreas, circumportal pancreas, and intrapancreatic accessory spleen, and anomalous pancreatobiliary junction. So pancreas divisum represents the most common congenital anomaly. Even though we see 3 to 7% of ERCP series showing pancreas divisum, majority of them may not have any symptoms. So the chronic pancreatitis may develop in a few percentage of patients having actual pancreas divisum. So this is because of the ventral and dorsal pancreatic duct fail to fuse, resulting in two pancreatic ducts that are separated. So the major part of the pancreas is drained through the smaller minor papilla. So when you see the MRCP, you can actually see the crossing duct sign. CPD and main pancreatic duct can actually be seen crossed. So these patients may develop with recurrent abdominal pain, recurrent pancreatitis, or sometimes they may present with something known as Santorini seal. You can see the bulging of the arrow represents the bulging of the terminal part of Santorini duct. The second type is the annular pancreas, where the pancreatic tissue actually encircles the second part of duodenum. This is the second most common congenital anomaly seen in around 1 in 20,000 general population. You can have two types. One is called the extramural and other is called the intramural. So it may result either from addition of ventral pancreatic bud to the duodenum or persistence of a left ventral bed. So during development, it is described that there are two ventral beds. One is the left ventral bud and other is the right ventral bud. The left ventral bud usually disappears and right ventral bud persists. If there is persistence of left ventral bed, you may develop annular pancreas. So it is complete in only 25% and incomplete in 75% as a ring, and it is frequently associated with other congenital anomalies. So extramural versus intramural, there is a difference in clinical picture. Extramural ventral pancreatic duct encircles the duodenum to join the main pancreatic duct. So there is a single duct actually joins the main pancreatic duct. Whereas in intramural, pancreatic tissue is intermingled between the muscle fibers of duodenal wall, and there are multiple small ducts directly entering in the duodenum. So extramural actually presents with features of high GI obstruction, whereas intramural presents with features of duodenal ulceration. So dorsal pancreas agenesis. This is a rare anomaly, but we may occasionally see patients with absent looking pancreatic body and tail. This may be due to fat replacement, which you get in patients with chronic pancreatitis. So you have to differentiate dorsal pancreas agenesis from the fatty replacement of distal pancreas. So the left side picture shows dorsal pancreas agenesis. You can see the pancreas closely abutted by the stomach, whereas the lower picture shows fat replacement of the dorsal pancreas, where you can see there is a gap between that pancreas and the stomach. That is represented by the normal pancreatic tissue, which is completely replaced by fat. Heterotopic pancreas is otherwise called the ectopic pancreas. You can see pancreatic tissue separated from normal pancreas. It is seen in around 0.6 to 13.7% of general population. Few days back, Dr. Shankar demonstrated a lesion in the ampullary area. Finally, it turns out to be heterotopic pancreas. This is the most common location is in the proximal GIT, and stomach represents the most common site, followed by duodenum and jejunum. Usually, the size is usually less than 2 centimeters and usually seen as a submucosal lesion on endoscopy. So CT may be helpful to differentiate GIST or other submucosal lesion from heterotopic pancreas. So you can see the upper image showing a gastric heterotopic pancreas, and the lower image showing a tumor arising from heterotopic pancreatic tissue on the duodenal wall. So this is another congenital anomaly. It's called circumportal pancreas. I have not seen so far, but it is seen in around 1.1% to 2.5% of patients. The pancreatic tissue encases the portal vein or superior mesenteric vein. It results from the abnormal fusion of dorsal and ventral pancreatic bed. Usually it is asymptomatic, and it is clinically important to recognize prior to a major pancreatic surgery, that is pancreatic head resection, or if you want to dissect the neck of pancreas from the portal vein. It is very important, and it is classified according to the course of main pancreatic duct and the relationship between splenic vein and the fused pancreas. If the pancreatic duct courses anterior to the portal vein, it is called anteportal, and if the location is above the splenic, it is called suprasplenic. Like it is retroportal, suprasplenic, anteportal, infrasplenic, and retroportal, infrasplenic. So this is the image showing circumportal pancreas, where you can see the pancreatic tissue completely encircling the portal vein, superior splenic vein junction. So intrapancreatic accessory spleen is a common lesion seen in pancreas, but when it occurs inside the pancreatic parenchyma, it may develop something like a pancreatic tumor, and if you do CT, and you may be likely to diagnose it as a pancreatic cystic lesion or pancreatic tumor. But if you see the signal intensity, the spleen and the heterotopic intrapancreatic accessory spleen both will have the same enhancement pattern on MRI. Sometimes the cyst may develop in this spleen, and that may be a differential diagnosis of pancreatic cystic lesion. And technetium 99M RBC scintigraphy helps to diagnose accessory spleen accurately. So here you can see the upper part showing a lesion in the pancreatic tail region, and finally it turns out to be an accessory spleen. So now the last variety is the abnormal pancreatic or bile duct junction. The pancreatic duct and bile duct joins outside the duodenal wall to forming a the common channel in 1 to 2 centimeters. Then APBJ is associated with more than 90% of patients with type 1 and type 4A choledochal cysts. Other choledochal cysts are also not associated with abnormal pancreatic duct bile duct junction. There is a high incidence of carcinoma gallbladder and bile duct cancer in patients with abnormal pancreatic bile duct junction. In patients with abnormal pancreatic bile duct junction, one can demonstrate abundance of pancreatic tissue in the head. It may be resulting from delayed recanalization of bile duct by persistence of left ventral pancreatic enlargement. So abnormal pancreatic duct bile duct junction without dilatation of the bile duct occur when ventral pancreas fuses with dorsal pancreas in an oblique position. Usually they join in a horizontal position, but when they join in an oblique position, the APBJ develop, but there is no dilatation and they are not developing choledochal cysts. So the two main classification system, one is the Japanese Society classification. They classified as type A, type B, type C, and type D. Type A is a stenotic type, type B is non-stenotic type, type C is dilated common channel type, and type D is complex type. The Comey's classification, they are divided into 1, 2, 3, and they are again divided into 1A, 1B, 2A, 2B, like that. They're a little complicated, and I won't go into the detail of that. So I'm coming to the surgical anatomy of pancreas. As you all know, the pancreas is located in the upper part of abdomen behind the stomach. In fact, it is considered as part of stomach bed. It is divided into the head, uncinate process, neck, body, and tail. Head and body are retroperitoneal, and tail of pancreas actually seen in between the layers of mesentery or the omentum, and that is intraperitoneal. So clinically, if you see a lesion arising from the tail, it can have features of an intraperitoneal lesion. But head and body are retroperitoneal. The head and uncinate process occupies the C loop of duodenum, and neck is the part of pancreas which is the thinnest portion, and it is lying anterior to the aorta and representing the junction between head and body. The tail is defined as 1/4 of the organ from the tip of the tail. So the last 25% of pancreas is actually representing the tail of pancreas. Pancreas has a length varies from 14 centimeters to 25 centimeter, and it weighs around 100 to 110 grams. So this is the comparative picture of CT and drawing of pancreas relation. You can see the IVC and aorta are related to the posterior part, the duodenum on the left side of the head, and the portal vein and superior mesenteric vessels are related to the neck and uncinate process of pancreas. So in the normal anatomy, you can demonstrate all the major vascular structures. You can demonstrate the abnormal vessels arising from superior mesenteric artery, and you can actually plan a pancreatic resection based on a high quality multi-detector CT. So these are the relationship of pancreas, the anterior view of pancreas showing the relationship with major vessels including IVC, aorta, superior mesenteric, inferior mesenteric vessels. And when you see the intra-operative picture, you can see they are very closely related to the renal vein. The head of pancreas is related to the renal pelvis, kidney, renal arteries, etc. So it is not demonstrated here, but during surgery, if you have to be very careful while dissecting the duodenum from the IVC. If you go too much into the Gerotus fascia, you're likely to injure the renal structures, including the renal vessels. So the posterior surface may be related to the third portion of the common bile duct. The common bile duct has got supra duodenal, retroduodenal, and infraduodenal portion, and it may be partially covered by a tongue of pancreatic tissue seen in 44%. It is called lingual of the pancreas. It is actually a developmental abnormality, or it can be a normal thing where you can see the bile duct is covered by pancreatic tissue on either side, but they are easily separable without any vessels or anything which obstructs the view. And it is important when you dissect the bile duct completely as a part of excision in choledochal cyst or in patients with bile duct cancers. Bile duct may be completely covered by pancreatic tissue in 30%, and the duct is uncovered in 16.5%. And sometimes you can see two tongues of pancreatic tissue on either side of bile duct. So the next important thing about pancreatic anatomy is the fusion fascia. During pancreatic surgery, every pancreatic surgeon will go through this fusion fascia. Because when you do cauterization, you are actually elevating the pancreas and pancreatic head and duodenum from the IVC along the fusion fascia of treats. And when you dissect the pancreatic body and tail, it is you are going through the fusion fascia of Tolt, and it will be extending to the left and right side as the line of Tolt. So this is actually a loose connective tissue membrane containing important pancreaticoduodenal arcades of arteries and veins. These important structures, if you know, there are two types of pancreatic resection. In one thing, we try to preserve. That is called the conservating pancreatic parenchyma. You have the limited resections, duodenum preserving head resection and all. In patients who are planned for conserving pancreatic parenchyma, limited head resection, it is very important to avoid injury to the pancreaticoduodenal arcades. So you have to be very careful while you dissect the fusion fascia in the head region. When you do Coccus maneuver, the fascia actually adheres to the pancreatic parenchyma, and the pancreaticoduodenal arcades are actually seen between the pancreatic parenchyma and the fusion fascia of treats. And SMA, superior mesenteric artery, penetrates the fusion fascia. So this is the development of this fusion fascia. You can see the ventral pancreas actually rotates anti-clockwise, and it lies on the lower part of the dorsal pancreas, and the fascia on the body tail region becomes the fascia of Tolt, and the fascia of treats actually seen in the posterior part of head, and it is penetrated by the superior mesenteric artery. You can see in this image. So this is the cadaver dissection of this fusion fascia. You can see the upper picture showing the fusion fascia intact of the what is called the fusion fascia of treats. And if you remove the fascia of treats, you can see the pancreatic duodenal, the superior, posterior, superior pancreatic duodenal vein comes into view. So that fascia is very important as far as the surgeons are concerned. The second thing about the pancreas is its attachment to the duodenum. We may think that the pancreatic head is completely attached to the C loop of duodenum. In fact, that is not the situation. The head of pancreas is loosely attached to the C loop except at 2 points, one at the major papilla and two at the minor papilla. At the major papilla, pancreas appears to be attached to the duodenal wall only by the ductal system. The pancreatic tissue will not enter into the duodenum. The parenchymal invasion occurs only at the level of minor papilla for about 1 to 2 centimeter, and the orifice of minor duct is situated eccentrically in this invaded area. So when you do duodenum preserving pancreatic resections or pancreatic head preserving duodenal resection, this knowledge of anatomy is very important. You need to just conserve the area of papilla and you can remove the rest of the duodenum or pancreas. So this is the representative picture where you can see the area of pancreatic parenchymal invasion of the duodenum. But the right picture actually shows the ductal location in that invaded area. It is actually situated eccentrically rather than in the middle of that invaded tissue. So the next thing is the pancreatic ductal anatomy. The pancreatic duct is usually situated more towards the upper part of pancreas, more towards the posterior part of pancreas. Because when you do pancreatic resection, if you transect the neck, you can see the location of pancreatic duct is more posterior, and they are the one which are likely to have more leak. When they are situated more towards the anterior part or when they are situated more towards the middle of pancreas, you can actually have a completely encircled anastomosis. So you can see the type 1 is the normal, type 2 there is equally the minor duct actually becomes the minor pancreatic duct is the main one. Type 3 absence of this duct, and type 3 you have two types. One is complete absence and the two is it is not entering into the duodenum. And type 5 you can see the what is known as the ansa pancreatica. So the main pancreatic duct and accessory pancreatic duct are lying in an anterior plane to the major pancreatic vessels. So they are little away from the major pancreatic vessels until you have an atrophied pancreas. If you do surgery on an atrophic pancreas, especially in patients with chronic pancreatitis, sometimes you can see the pancreatic duct is very close to the portal vein superior mesenteric junction. Sometimes it may be actually injured. So the main pancreatic duct originates in the body tail region and continues towards the head, but majority of it is drained through the major papilla through the ventral duct. So it has a length varying from 17 to 27 centimeters, and the diameter it is described as 3, 2, 1, 3 in the head, 2 in the body, and 1 in the tail region. The accessory pancreatic duct is absent in 15 to 30% of individuals. You will see only a single pancreatic duct. If there is failure of fusion of these two ducts, and if you go too much towards the pancreatic head during pancreatoduodenectomy, sometimes you may encounter two pancreatic ducts. So there is a classification called Michels Classification that there are three types described. One, type 1, the pancreatic duct opens into the CPD at a variable distance from the opening in the major duodenal papilla. That is known as the common channel, and it is seen in around 85% of individuals. Type 2, the pancreatic and bile duct opens, but they have separate opening in type 3. The type 2, they have very close opening, but they are opening separately. Type 3, they have a separate opening and they are all separate by some distance. The sphincter of Oddi is the sphincter of pancreatobiliary channel, which has got 4 parts. One is the sphincter pancreaticus, the 2, 3 are the superior and inferior choledochal sphincter, and the fourth one is the sphincter of the ampulla around the ampulla itself. So when you do pancreatic surgery, the most important thing is the vascular relations rather than the actual organs related, like kidney or, because there are some vessels which you can actually ligate as a part of pancreatic surgery. There are some vessels which you cannot ligate, and in some patients, especially having celiac stenosis and all, ligating a gastroduodenal artery produces more harm to the patient because it will actually steal the blood flowing to the liver. So these sort of vascular anomalies has to be identified in the pre-operative image itself. So you can see pancreas actually represents the boundary between foregut vessels and the midgut vessels, and the pancreatoduodenal arcade is the communicating vessel between the foregut arteries and midgut arteries. So whenever there is obstruction of any of these vessels, we can have increased flow through this arcade. The splenic artery actually is supplying the body tail region of the pancreas. In some patients, there is an artery toward the body and tail region, which may be supplied by the gastroduodenal itself. And during pancreatic surgery, if you ligate these vessels, in rare situations, you can have necrosis or ischemia of the pancreatic stump. So the splenic artery will give rise to dorsal pancreatic artery, inferior pancreatic artery, greater pancreatic artery, or otherwise called the pancreatica magna or artery of von Haller, and it gives smaller caudal pancreatic arteries. So when the arterial supply goes towards the tail of pancreas, they are all small, where you can actually coagulate using bipolar. When you are dissecting the pancreas closer to the body, you may encounter larger vessels. The caudal pancreatic arteries are actually giving supply to the splenic hilar area. So the arterial supply of head can be demonstrated after removing the head of pancreas. You can see when you remove the head, you can see the bile duct exposed, the posterior and anterior superior pancreaticoduodenal arteries are exposed. Interestingly, the anterior inferior pancreaticoduodenal artery is situated in the posterior surface of pancreas. But when it comes to the duodenum, it will be on the anterior side. So in the dissection specimen or in the operating specimen, we will see the anterior pancreaticoduodenal anterior inferior pancreaticoduodenal artery posterior to the uncinate area or the body of head of pancreas. So this is the actual anterior inferior pancreatic artery. You can see it is going through the posterior part of pancreas. So this is an important thing which I consider it is important, because if you do pylorus preserving pancreatoduodenectomy, by the time you resect the the duodenal D1, and if you start anastomosing, you may see a discolored area at the anastomotic site, because the arcade which I have shown is very important, because if you can preserve that arcade area, this is called the gastroduodenal arcade, you can actually get a very vascular duodenal stump by the time you do the anastomosis. There are many arterial variations described. The mesenteric celiac trunk, it's a common trunk between superior mesenteric and celiac, seen in around 2.8%. The very important arterial variations are one is the replaced arteries, that is the replaced hepatic or replaced common hepatic or replaced right hepatic, because when it is replaced, the location will be on the right side of the CPD, and during dissection of the bile duct, we may likely to injure these vessels. If you follow the protocol of artery first approach, which I will come later, you can actually identify these vessels early in the course of your dissection. The inferior pancreaticoduodenal artery, even though the textbooks describe it arises from the superior mesenteric artery, the majority of them actually arises from the first jejunal artery rather than the superior mesenteric artery, and it will arise as a common trunk and then divides into the anterior and posterior inferior pancreaticoduodenal vessels. And sometimes the relationship between superior mesenteric vein and artery is inverse, even in 4.1% of patients without a malrotation. If you see inverse relationship between superior mesenteric vein and superior mesenteric artery, we are likely to diagnose malrotation. But without malrotation, we can see inverse relation in around 4.1%. So this is the one which I was mentioning. You can see the inferior pancreaticoduodenal arteries. Majority of them arises from the first jejunal artery and usually arises as common trunk. And if you go too much towards the jejunal artery, you can actually get a single trunk of inferior pancreaticoduodenal artery. But if you go towards the uncinate area, you may get two branches. And the right picture actually shows the location of the anterior inferior pancreaticoduodenal in relation to the pancreas and in relation to the duodenum. When it comes to the mesoduodenal area, it actually lies in the anterior part of mesoduodenum. The venous anatomy of pancreas is actually more important than the arterial anatomy, because nowadays, even if there are venous infiltration, we can actually do venous resection, provided there are vessels proximal and distal which can be anastomosed after resection. But if there is an arterial involvement, majority of them tend to be a non-resectable lesion. So you know which vessel is important, which vessel is we can compromise, etc. The venous drainage of head of pancreas and duodenum, there are arcades, but the anterior pancreaticoduodenal arcade is seen in majority of the cases, but posterior pancreaticoduodenal vein arcade is seen in less than 80% of individuals. The important vein, which is known as the Belcher's vein, that is the posterior superior pancreaticoduodenal vein, is known as Belcher's vein because it is named after a surgeon assistant, because it's a short vein which connects the portal vein, the upper part of pancreatic head, and it always almost always comes in the way of your dissection of the portal vein. So it's called Belcher's vein, or otherwise it's a posterior superior pancreaticoduodenal vein. If you don't know this vein, and if you dissect the portal vein during pancreatic head resection, sometimes you will injure this vein and there will be torrential bleeding. The anterior superior pancreaticoduodenal vein actually drains into the gastrocolic trunk in majority of patients. I will come to the gastrocolic trunk little detail later. The gastrocolic trunk then joins the superior mesenteric vein. The actual trunk of superior mesenteric vein is between the entry of gastrocolic vein and formation of the superior mesenteric vein by the joining of iliac and ilial and jejunal veins. So this is the SMV trunk conformation. The single major trunk of SMV seen in 92.5%. Sometimes you may have absent trunk with jejunal and ilial branches directly joining splenic vein to form a portal vein. The first jejunal vein is a very important vein during pancreatic head resection. It is usually seen anterior, it's usually seen posterior to the superior mesenteric artery and anterior to superior mesenteric artery in only 26%. Then the joining of inferior mesenteric vein is also important, because the inferior mesenteric vein joins splenic vein in 55% cases and superior mesenteric vein in 31%, and only in 11% it joins SMV, so splenic vein confluence. The left gastric vein usually joins the portal vein in 58% and splenic vein in 35%, and superior splenic vein superior mesenteric vein confluence in only 6%. So this is the Henle's trunk, because whenever you start dissecting for pancreatoduodenectomy, you will come across this trunk. The Henle's trunk is actually a union of foregut vein and the midgut vein, because the right superior colic vein is actually draining the midgut origin structures. So the foregut origin vein, that is the right gastroepiploic vein, joins the right superior colic vein, and it is draining another vein. It's the anterior superior pancreaticoduodenal. All these three veins join to form what is known as the Henle's trunk. And for identification of superior mesenteric vein at the neck of pancreas, majority of surgeons usually dissect the trunk early in the course of surgery. So you can have actually you can have 5 types of Henle's trunk depending upon the veins forming the Henle's trunk. But in majority of cases, there will be 3 veins joining it. One is the right gastroepiploic vein, second is the anterior pancreaticoduodenal vein, anterior superior pancreaticoduodenal vein, and third is the superior right colic vein. So these are the pancreaticoduodenal vein, and the posterior vein is in very close relationship with the posterior part of bile duct. So this is the first jejunal vein which I was mentioning. You can see the jejunal vein, the first early in the dissection of uncinate process. You can, on the left side, you can see it is just seen in the duct. And when you dissect further, you can see the inferior pancreaticoduodenal vein actually arising from the first jejunal vein. Previously, surgeons used to ligate the first jejunal vein to avoid bleeding. Now, with the advent of newer electrosurgical equipment, bipolar, you can actually save the first jejunal vein because it will help to decrease the congestion. The first jejunal vein, if it is very patent, and you can actually resect the part of superior mesenteric vein, if you can avoid the entry, if you can actually save the entry of splenic vein into the portal vein, because the jejunal vein forms the circulation for the portal vein. Because if there is thrombosis or if there is tumor involvement of the superior mesenteric trunk distal to the entry of first jejunal vein, you can actually compromise that area without a vascular anastomosis. So this is a lymphatic drainage of pancreas. You can see the head is drained by gastroduodenal and the posterior and anterior pancreatic lymph nodes, and sometimes it may drain the superior mesenteric lymph nodes also. The lymph node dissection of pancreas is divided as the standard lymph node dissection and extended lymph node dissection, depending upon whether you resect the lymph node in the pancreatoduodenal area, or if you go dissecting the hepatic artery, the superior mesenteric artery, and the area in the renal hilum. So the lymphatic drainage, the standard regional lymph nodes draining the head and neck are along the CBD, along the common hepatic artery, portal vein, posterior and anterior pancreaticoduodenal arcades, along the superior mesenteric vein, and the right lateral wall of superior mesenteric artery. Those draining the body and tail lie along the common hepatic artery, celiac axis, splenic artery, and splenic hilum. According to their relation to the pancreas, regional lymph nodes are described in 5 main groups. One is the superior node. This is for the body and tail region. You have the superior node, you have the inferior node, you have the anterior node, you have the posterior node, and lastly the splenic nodes. And if you see the literature by the Japanese or the Germans, you will see they are giving too much importance to the pancreatic nerve plexus, because preserving the pancreatic nerve plexus to the left of superior mesenteric artery is very important to avoid the dysfunction of the bowel. If you resect the nerve plexus to the left of superior mesenteric artery, the patient will have intractable diarrhea. So the nerve plexus can be divided into one is called the PL-PH1, that is actually the pancreatic head plexus one. The other is the PL-SMA, that is the superior mesenteric arterial plexus. But we will not usually resect the PL-PH2, because if you resect that, patient may develop intractable diarrhea. So another concept in pancreatic surgery is the mesopancreas. This is an example of that. We dissect the pancreas entirely, the pancreas and duodenum on the right side. We don't actually go to the ligament of Treats area to dissect the proximal jejunum. So here we can see the pancreas is, the duodenum is actually transected after dissection of the uncinate process. So this is the concept of mesopancreas, where you see the posterior view on the left side and the anterior view on the right side. Because if you see the literature on pancreatic cancer surgery, majority of the margin positive resections are seen in that area of the groove margin or the superior mesenteric artery margin. So they created a concept known as the mesopancreas concept, where you dissect the mesopancreas completely going from the left side of the superior mesenteric artery and completely removing all the tissues related to the head and uncinate area, so that we will give maximum negative margins. So the lower image is showing the complete bearing of the vessels, including the superior mesenteric, celiac axis, the vena cava, the portal vein. This is known as the 5 vessel clearance by some oncosurgeons. So when you see the pancreatic surgery, if you can actually dissect the neck of pancreas, you will feel you are safe. That means you can actually complete the procedure by dissecting the pancreatic head and uncinate process from the rest of the vessels. The middle picture actually shows the area of mesopancreas. This is the early in the course of pancreatic uncinate dissection. And finally, the right picture actually demonstrates completely the uncinate and its relation to the superior mesenteric artery. So for practical purpose, for hepatic pancreatic biliary venous system, they have divided into 5 zones. One is the zone 1, that is actually in the liver hilum. Zone 2 in the hepatoduodenal ligament area. Zone 3 is the splenic superior mesenteric vein portal vein confluence. That is 3A, it is actually in the right side, and 3B is on the left side. Zone 4, the infrapancreatic SMV and the confluence. And zone 5 is the splenic vein. So when a pancreatic surgeon is concerned, the zone 3, zone 4, and zone 5 are important. So when you see zone 3, the important tumors which infiltrate this area is the pancreatic head tumor. Zone 3A, it may be infiltrated by pancreatic neck tumors. And zone B usually seen involvement by pancreatitis pattern rather than the tumor infiltration actually. The infra confluence usually infiltrated by the pancreatic head tumors, and splenic vein involvement, that is the zone 5, usually seen in body and tail tumors. So if you have the vascular infiltration, if you have the zones involved, you can have different procedures described. If you have involvement of the splenic vein, portal vein confluence, there is a procedure known as the WhatsApp procedure. I'll come to it later. The second is when you have involvement of the left splenic vein, portal vein confluence, you have what is known as the Ram's procedure. So this is the WhatsApp procedure, that is the Whipples at the splenic artery, where you will not transect the neck of pancreas. Instead, you will go towards the splenic vein area, resect the tumor there, and resect the pancreas there, and remove the entire specimen towards the left. That is known as the WhatsApp procedure, or Whipples at the splenic artery. It is described by Strasberg et al. The second procedure is the RAM, that is the radical antegrade modular pancreatosplenectomy. This is another procedure described for complete removal of the pancreatic tumor with the removal of all the lymphatics with a clear negative margins. There are 2 RAMS procedure. One is the anterior RAMS, where you will not remove the adrenal gland on the left side. Posterior RAMS, you will include the adrenal gland on the left side. The another concept is the artery first approach, where you actually dissect the superior mesenteric artery. This is very important because during usual pancreatic head resections, you will dissect the superior mesenteric artery at the last. And if you transect the neck of pancreas and if you find there is infiltration of the superior mesenteric artery, you cannot proceed further. Instead, you will create what is called an R2 resection. So to avoid this, there is an approach known as the artery first approach. Different surgeons use different approaches for approaching the superior mesenteric artery. One is called the posterior approach. Second is called the medial uncinate approach. Third is called the infracolic. Fourth is called the left posterior. Fifth is called inferior supracolic. And last is the superior approach. There are 6 different approaches, but most of the surgeon utilizes the left approach or the actual posterior approach. That is a good old approach done by most of the surgeons. So with that, I will come to the actual anatomy of pancreas, which is important for a surgeon. But if you want to expose the pancreas, you need to know certain procedures. One is the cattle brush procedure, other is the coccus procedure, and there is a concept known as the reverse cockerization, which is popularized by the Japanese people. The concept of reverse cockerization is that when you do a cockerization, actually you are handling the tumor tissues. So there is a chance of tumor spillage into the veins and there is a chance of dissemination. But if you do a reverse cockerization, you will not handle the tumor and the ampullary area of the head region, and you will in fact do the dissection from the left side of superior mesenteric artery and come to the right side, and the cockerization is done from the left towards the right. So that is called the reverse cauterization. So this is the actual exposure. You open the lesser sac, you dissect the inferior margin of pancreas where you can see the vessels entering. Then you identify the gastrocolic trunk, ligate it. You may be able to preserve the middle colic trunk sometimes, but majority of cases we may have to sacrifice the right superior colic vein. And finally, you will do cauterization. You will expose the IVC up to the duodenum is cauterized, and you will demonstrate the left renal vein or aorta. You may take samples from the interaortocaval area. And finally, this is the reverse cauterization which I was mentioning, where you have a medial to lateral dissection like you see in the no-touch technique for rectal surgery, where you can see they are dissecting from the left of superior mesenteric artery, and the direction of dissection is demonstrated that you will remove all the retropancreatic tissue, including the right nerve plexus, and then comes to the tumor area, and finally you remove the tumor. That is called the reverse cauterization. So with that, I come to my talk on surgically relevant anatomy of pancreas. If you have any doubt, I think I may be able to clear if possible.
That's a wonderful talk, Prathapan, because there's so many new things many of us got to learn, and I'm sure this will sort of make us understand pancreatic surgery better. Ilango, there you are.
Sir, Prathapan, wonderful lecture. wonderful lecture. I think for the youngsters, these are the concepts that you have to pick up to become a good pancreatic surgeon. You should get the references from Dr. Prathapan very, very consistently. I mean, I think the BJs from John Winsor's group and Sailesh Srikande, it's a classic. And I learned when that paper came in, John Windsor had actually discussed the different approaches in a previous IAS GCon. I don't remember the place. I think it was in Jaipur. His lecture was actually cut short at that time, and I was so mad at not having learned that 6 approaches. I was just out of MCH at that time, but that reference in 2000, published in 2012, is very close to my heart, and it serves me very well. But I usually mix up the arterial approach now. I use the inferior infracolic and along with the posterior.
Yeah, vascular surgeons, when you go to the liver transplant area, you are actually going to the infracolic approaches because you have the technique of anastomosing early. There's some Japanese surgeon, they routinely do the infracolic approach without touching the pancreatic head. That is the no-touch pancreatic surgery. I have seen in one of the conferences, they demonstrating it. I was worried why they do resection of pancreas routinely in patients with pancreatic cancer. But we do cases with portal vein resections occasionally.
So once you get familiar with that, my initial, when I did the initial resection, I usually had one of the seniors on the phone or nearby, and I usually used to ask one senior vascular surgeon, Dr. Shekhar, used to help me out. But now, once you get familiar with the technique, this is the key anatomy. And I always tell that the first jejunal artery and the inferior pancreatoduodenum, they come close to each other, and they usually have a single stump, and you have to resect it very, very carefully. And those are very, very good points. And I really liked the zones for the venous involvement and the different techniques that you can use. Wonderful information. I think it's a lecture worth preserving for the HPV series. I think we should stock this up and put it up regularly, sir, under some heading.
Prathapan will be coming with clinical anatomy. Prathapan, I have a question. Now, when you do lateral pancreatoduodenectomy or phrase procedure, as you see, when the pancreatic gland shrinks, then the vessels may come very closer to the place where you cut. What are all the anatomical considerations you'll be worried about? Where all bleeding can occur when you're operating on a chronic pancreatitis for Whipple's or phrase procedure? Because quite often we forget the fact that the pancreas is thinned out at places and the portal vein is closer or some other arteries are closer. What will be your concern when you operate on chronic pancreatitis?
The three things which are important. First, you have to exclude there is no thrombosis of the portal vein or superior mesenteric vein, because if there is a thrombosis, you may get a large veins developing in the pancreas, and during the pancreatic what you call the opening of the pancreatic duct, you will see the veins from both sides bleeding into the pancreatic duct, very difficult to control. That is one point. Second point, if you have no evidence of thrombosis and the parenchyma is thinned, you try to dissect on the stone which is palpable and then identify the pancreatic duct and lift the pancreatic duct up, and using bipolar slowly dissect rather than cutting through the pancreatic parenchyma using the monopolar. Because once I cut like that, I actually transected the superior mesenteric vein, and it was very difficult to do repair with a partial pancreas attached to the superior mesenteric vein. The third thing, you can actually dissect on either side of the superior mesenteric vein, and you can actually pass some instruments and you can try whether there is a stricture or not. If there are no strictures, if it is difficult that area, you can actually skip that area and do anastomosis on either side. Nothing will happen. The head of pancreas, most of the time, you can actually control the vessels by multiple sutures. I usually put sutures in the named vessel area first, and when I start dissecting the pancreatic head region, I will actually take multiple bites, figure of 8 sutures. I think doing phrase procedure on a background of portal vein involvement is very difficult.
There are sometimes when we cut open the pancreatic duct and come very close to the duodenum, the arterial bleed will happen. It happens quite often actually. Actually, that also happened post-operatively where patients sort of bled into the...
I have one patient underwent angioembolization because there was torrential bleeding. Young boy.
How do you, because it's very difficult in the pancreatic parenchyma, especially in chronic pancreatitis, locate one of the arcades. You know, the arcades, unless until we injure the arcade, we do not know there's an arcade there.
No,
I think there is a...
yeah, tell me.
Prathapan, go ahead. You can make it.
Actually, if you know the intraoperative anatomy, the anterior arcade is seen very close to the duodenal C loop, and the posterior arcade is very close to the superior mesenteric loop. Actually, it is not exactly opposite. It is like this. So it is easy to preserve the posterior arcade when you do transection and the removal of the head of pancreas. That is why most of the duodenum preserving head resection, they preserve the posterior capsule and posterior vessels, because preserving the anterior is more difficult than preserving the posterior.
You're saying something?
I think I also learned the same techniques. So I don't know how AIMS taught you. HR usually takes it like TURP, sir. So he sleeves and we put stitches all the time. So that is the only head coring I ever learned. For a long time, Dr. Sadiq Sikora and Dr. HR taught like that. So I have been doing like this. I have never seen otherwise.
Even to say...
Only when I came to MIOT, I realized Dr. Surendran was telling me I will never do like this. So I realized, there is an alternative way. They usually take in a chunk. Because if you take in a chunk, I find it very difficult to control. The small sleeve, I take a stitch. So there will be multiple.
You take a stitch, Lango, but again, with the stitch, you go to core some more tissue, no? If you take a stitch, you don't go any further.
No, sir, it will be on the side wall. The bleeding on the side. Yeah. It is not on the depth, sir. It is on the side wall that's close to the duodenum. Usually small stitches, 40, 50 I use.
And how do you avoid the portal vein? Because as you keep going deeper and deeper, somewhere it'll come very close. You can't palpate it.
So I had this problem when I started practice in 2011. I got caught. So the simple technique in that situation is to split the pancreas and then go and get that. Invariably, it will be one small twig from the superior mesenteric vein, sir. So what I after that one incident, what I started doing was take the duct in the body, and then I work down and I take the uncinate duct. So the uncinate duct, I am very careful. On the head, I come down, I core a portion, then get the uncinate duct, put a right angle inside and keep on one hand and then slowly dissect on the top. So that after that, I have stopped avoiding. The first time when it bled, I had kept the right angle inside the uncinate duct. It slipped off. And the person who was assisting me was a medical gastroenterologist. There was no other person to assist me. So he said, I want to introduce. I said, okay. And he promptly poked the vein. I was very upset. All I did was I asked him to hold for some time. I went out for coffee, came back, split the pancreas and did the stitch. There was nobody to help. After that, I have never given anybody the chance to put a right angle inside the uncinate duct.
See, because of the fear of injuring the portal vein, and many a times, at least I don't exactly completely destone the uncinate and that area. Some bit of is always left behind because I have this fear that this stone itself might injure the portal vein when we are trying to manipulate it.
I see that, sir. So for that, Prathapan, you want to take that question? I will also add up. You have some suggestions on that?
Do you completely take the stones out of the uncinate process?
Yes, sir. We usually take, unless there is venous thrombosis or collaterals. Most of the cases we go up to the posterior capsule and remove all the stones in the pancreas. And if you go deeper, you will see actually there is a duct going posteriorly, and open that you will see large stones. If you need me to demonstrate that video, I have a video on that. I was stopping at one level, and when I palpated, there was a stone. Went in and removed a larger stone, which was larger than the stones which I removed earlier. So I think removing the entire duct system, entire stones, and removing the entire core of pancreas is possible unless there is a portal vein thrombosis or cavernomas. Otherwise, it is possible.
Any other questions? I think there's a question in the chat box.
Yeah,
Sir,
I'll take it. Kind elaborate on the importance of the first jejunal vein with relevance to operability.
No, first jejunal vein, I have demonstrating that. There was a study by one of the pancreatic surgeon where there is an infiltration to the superior mesenteric vein, but the first jejunal entry into the vein was lower because the tumor was infiltrating superior mesenteric vein after the first jejunal vein was joining the superior mesenteric vein. So they resected that part without reconstructing it because the venous drainage occurred through the jejunal vein into the middle, the inferior mesenteric vein, and finally to the splenic vein. So this is possible only when the splenic vein superior mesenteric confluence is intact and the first jejunal vein joins the superior mesenteric vein below the infiltration site. That means the superior mesenteric vein, first jejunal vein entry is not compromised. Okay. You can see in neck tumors, sometimes in neck tumors, you can have this sort of infiltration. You may be able to avoid the splenic vein, avoid the portal vein, but you may be able to resect the superior mesenteric vein because the jejunal vein actually become bigger sized and that will actually drain the rest of the venous system.
For a classical venous resection, first jejunal vein has to be controlled.
Yes.
Because it is likely to be avulsed and it gets retracted on the left side of the superior mesenteric artery. So in a classical venous resection in pancreatic tumors, especially close to the uncinate, I invariably control the first jejunal vein. I'm very, very careful. That also I learned only by bad experience.
Yeah, I think in the beginning of pancreatic surgery, most of the surgeons used to take the jejunal vein along with the specimen. And as you get experience, you will actually dissect the jejunal vein from the inferior pancreaticoduodenal vein and ligate only the inferior pancreaticoduodenal vein. Now we ligate only that. We don't go to the jejunal veins because dissecting the jejunal vein is actually a waste.
Yeah. It's only when you, it's that the only requirement is when you apply the clamp, it sits there.
Yeah, yes.
So it gets injured very much. Otherwise, you don't have to touch the first jejunal vein. You're right. So do we normally get a transverse pancreatic artery? Like in lab distal pancreatectomy, we safeguard splenic artery and the splenic vein, but rarely worry about the distal pancreatic artery.
Yeah.
Now,
there are transverse pancreatic artery described, but these arteries will become large when there is some obstruction to the splenic arterial flow. Sometimes there may be some compression on the splenic artery. The arcade vessels will become larger. So if you see a larger vessel during your dissection in the lower part of the pancreas or posterior part of pancreas, you have to control it better with a hemolog clip or some major hemostatic method. But if you go towards the tail, you can actually control them by bipolar or even the harmonics.
Prathapan, do you ever take stitches when you do lateral pancreatoduodenectomy in the pancreatic parenchyma? Isn't the bipolar good enough?
Yeah, most of the, except in the head region, we will ligate, we will do transect, what do you call the longitudinally incise the pancreatic duct. But in the head region, the bleeding will occur from both sides.
Right.
Whereas in the duct region, the splenic artery is the one which gives major bleeding rather than the inferior vessels. Because in atrophic pancreas, in chronic pancreatitis, majority of the vessels will die off. Only very few vessels remain. Okay. So the most of the bleeding in the body tail region occurs from the splenic arterial flow, and in the head region, since there is an arcade, you have the connecting veins and arteries between the anterior and posterior arcades. So you may have bleeding on either side. So I will take stitches on either side of my transection plane in the pancreatic head.
Any other comments?
Prathapan, you also do a full cauterization for your chronic pancreatitis, or you don't?
Usually I do, because unless you do a cauterization, the jejunal loop will not remain there in a very good position. You have to do complete cauterization, and it also helps you to control the bleeding. So whenever you transect the parenchyma, whenever you take the tissue, there will be bleeding, and if you have cauterized the duodenum, you can actually press it at that moment, and you can take stitches. It will give you maneuverability and free access for your bleeding, the bleeding control. So I think cauterization should be done in all patients plan for a phrase procedure. But if you do only lateral pancreatoduodenectomy, I won't consider cauterization.
Yeah.
Ilamo, there's an interesting question in the Facebook group. Of course, it's not related. Vinay Thakur says, what is the clinical implication of growth factor and how do you actually perform it?
I think Ilango is a better person to answer. He does vascular surgery.
So
growth factor and how do you actually perform it?
So when you finish a venous anastomosis, you are doing the anastomosis in a collapsed vein. So all veins are capacitance vessels. So when you fill it, it will enlarge. And if you have done the anastomosis tight, just like how you do a bowel anastomosis or an arterial anastomosis, the vein will be shrunken. So it will become narrowed when the vein actually enlarges. So this is something which Starzl was the one who actually created the growth factor. So he had the problem in his liver transplantation. So what they will do is, since you cannot assess very well, either you have to allow the vein to distend and then tie, which is a little difficult. You will have so many things to do in transplant. So they developed this thing called the growth factor. So you can, depending on the portal flow and the portal pressure and the ability to guess how the vein expands, you can give up to half of the diameter of the vein to a 1.5 also. Some people do with very large portal veins. So in a pancreas resection with venous resection, you do a growth factor about half. So that will expand the vein, and the vein will be exactly straight. Even a small stenosis and turbulence in the vein will produce clots. So to avoid that, that is the thing. So in case you do less, you will find that small waist. And if you do more, the vein will bleed a bit. So in that time, you just pull it for some time and then take one more stitch. The bleeding will actually stop. So growth factor is very, very important in venous anastomosis, especially when you're doing end-to-end vascular anastomosis. So how I do it is, when you finish the anastomosis, I have a mosquito on a shard. So I decide what length and I put the shard. Then I do a regular tie. So can you get that for me? So once you finish the tie, you'll have two strings. You apply the shard mosquito on that and then do the tie on that. So you don't have to do an air knot. To do an air knot, you need good skills. So instead of that, you can tie it on the shard and then release the shard. So you will have a good growth factor about the length you require. That should be the 0.5 to 1.5 times the size of the vein, depending on the portal pressure and the flow in the vein. Once you release that, it will happen. In case it bleeds, you just pull it, the bleeding will stop. And then you can take an additional stitch. Growth factor is very, very important in venous anastomosis. I think one of the key skills, key ways in which you can judge a surgeon is the ability to predict the exact growth factor. As you grow, you keep on doing venous anastomosis, you do that. Now, I'm so addicted to it, I do even for end-to-side venous anastomosis in kidney transplants, because it gives that rounded feeling to the vein. The vein should not be flat. So when you see the cross-section, it should not be like this. It should be like this. It should be like a rounded structure. So that will happen if you give a growth factor. In kidney transplants, you give a slight growth factor so that you get that rounded structure. So I hope I have answered.
I should tell you, I should admit that during my days with Professor Nandi, where pseudo-annular shunts, growth factor is very good, I thought that the children will grow sometime and it will just, that's how the growth factor is. But later on I realized it's not that, it's the veins only when they come to their normal shape that the suture snugly fits in. Now, actually, in those days, the patient used to be heparinized during the venous anastomosis, and then Prathapan is to be injected soon after the anastomosis is over, and dry sponges are kept like that for 5 minutes. We used to count for 5 minutes, for in the blood to clot, and that still happens, the heparinization and neutralization by Prathapan.
Sir, in US it was mandatory. When you put the clamp in a donor, you have to heparinize, give 3 minutes, 3000 of heparin in a living donor, and then 3 minutes, and then you have to give protamine. That was just a protocol, sir. Here, after I have come here, the donor surgeons, they may give heparin, but 3000 I think is a very small dose. Most of them skip protamine, sir. Apart from that, I don't do. For all the vascular anastomosis, I have heparin saline at 100 units per ml all the time. So I use that quite frequently. So that gives that protects the anastomosis, because now most of my vascular anastomosis are very small vessels, 2 mm, 2.5 mm from arteriovenous anastomosis. So those are prone for clotting. So that we will do. But large volume heparin I have not given here, sir.
Right. So any
Sir, I want to have I really want to hear the experience of portal vein surgery, portal hypertension surgeries from people who studied in AIIMS. It is all Dr. Nandi students always talk of shunts. I mean, I have done shunts, but it's very minimal. No, I usually go around and ask, what is this? All gastroenterologists are putting blue. We are not getting.
Yeah, see, one of the biggest drawbacks of general surgical training is lack of vascular training. I think we try suture tendons, we try suture muscle, we try suture bowel, but we do not know how to suture vessels. A majority, almost all the general surgical training, unfortunately, have no access. If you cannot suture vessels like you suture bowel, you can't use silk and do some suturing. There are some special techniques. That is the advantage most students who went through Dr. Nandi's unit had, because there we are suturing vein to vein. If you can suture vein to vein, you can suture anything to anything.
Anything. Yeah, I
Effectively,
agree.
so it's got so many small subtle maneuvers you need to do while suturing. Maybe one of the times I'll talk about portal adaptation. Maybe I can show how that is done. But then that's where it is. It's a very beautiful thing. If you know how can suture. But I think all general surgery postgraduates should go through some mechanism by which they are exposed to vascular surgery that can be life-saving, number of limb saving at least.
Incidentally, that was how I went for transplant, sir. I used to call Dr. Shekhar to be a support for whenever I have a doubt regarding portal vein infiltration in pancreas. And at one point of time, when I went to US, I told them, see, I was very unfortunate that the cardiovascular unit was, the theater was under repair during my entire postings. So I never had any exposure to vascular surgery during my MS, no exposure. So I felt very bad, but the transplant filled that gap. There is one more question, sir. This is very interesting. Ripples in a patient with previously performed gastric pull-up. Would you consider preserving GDA? Any thoughts?
Prathapan, you should take it.
I don't know. Why was the gastric pull-up done?
What is the reason for doing gastric pull-up?
Must be some corrosive.
Because when you do gastric pull-up, this entire stomach depends on these two vessels, the right gastric and right gastroepiploic. I think most two vessels has to be compromised before you do pancreatic head resection. Actually, I had a patient with gist stomach. I did a the proximal gastrectomy. After 2 years, patient developed an ambulatory tumor. They referred the case to me. I said I can't do Whipples because I already resected most of the stomach, and after the duodenum I have to take the jejunum into the esophagus for the anastomy. Because this sort of situation happens. I think you may have to consider some vascular reconstruction method. It is almost like the celiac artery stenosis patients, which you do a reconstruction of the hepatic artery to the aorta. Recently, I had a case of celiac stenosis where I had to do a reconstruction. So I think you can do, because the tumor is not infiltrating the vessels, you can actually do a vascular reconstruction and save the patient. But if it is the first surgery is done for a malignancy, I don't think there is not much benefit.
Any more questions or comments on the audience? Yeah, there's a question by Binay Thakur again. Do you recommend prophylactic heparin or low molecular heparin after vascular reconstruction after venous resection?
Not for the venous resection alone, sir. What I have been doing is use the regular DVT prophylaxis. That's all. I give DVT prophylaxis for everybody. That's all. I have not given anything special for venous reconstruction.
No. Heparin, when you use for venous reconstruction, we have to use the regular heparin because the low molecular weight heparin has no antidotes.
No, I don't use low molecular weight heparin for DVT prophylaxis. I think I'm one of those cheap surgeons.
No,
so,
I was not using it. I was
5,
not using it, but I had to change because I lost 3 patients because of massive pulmonary embolism. CT diagnosed massive pulmonary embolism. So DVT is not rare. DVT is common even after a pancreatic surgery. Even in patients with abnormal prothrombin time due to the obstructive jaundice, they may develop DVT. In cirrhotic patient, the coagulation failures occurs, but portal vein thrombosis occur even without tumors. So the body's coagulation mechanism is different from different individuals. But as a policy, I start in the evening of my surgery and continue for the next 5 days.
So our DVT prophylaxis policy is you unfractionate the heparin, 5,000 units subcutaneous BD. That's the only thing I do.
The reason why, yeah, you're saying something?
So the reason why I give that heparin is not because of the venous anastomosis. If the venous anastomosis is very well done, thrombosis is very rare. If you narrow it even a little bit, it'll get thrombosed. That is why you need to be very, very specific about the growth factor. And what is worrying for me is I put a bulldog on the SMA during the time when I have the venous clamps on. That is much more fearful. So that is the thing which I'm worried about. So I give them aspirin, especially when they are mobilized very well, and I give them aspirin. I don't give it for a long time actually, maybe a couple of weeks and then stop.
Interestingly enough, in portal appendage surgery, no anticoagulation is done after surgery. For the fear that the patient already has portal hypertension, they tend to bleed. But you know, the shunt thrombosis rate is anything of 13 to 15%. 13 to 15% get thrombus.
That is exactly why I wanted to see, sir. I have always been doing proximal splenorenal shunt in a very different way. My configuration is the upper edge of the vein is marked very well. These were things I picked up from operating with Dr. Kumar. He did one of the first surgeries I saw was a mesocaval shunt. He did it so, but he marks every part of the anatomy, the way the vein turns around, the way it finally lies, the heel and the toe, everything has to be planned very well. So when you assist him, there is no other way. You have to do it exactly the same way. He assists you, but he expects you to do exactly what he does. So the upper portion of the vein is turned and it gets good to the heel, and the lower portion of the vein comes to the toe. And the orientation is such that there is no kinking. So we usually take the longest part of the vein and then we tilt it around. So that's how I was doing. And the clamp is placed not on the upper edge. If you go to the upper edge, you will get only a thin slit. So it is slightly on the anterior wall so that you get that. So these variations I learned from him. But what I am very interested in is that it is no longer enough for me to see one surgeon and one particular technique with some mild modifications. I want to see how people in the AIMS actually did it. There's no place actually. I mean, you and Bhaskar sir always talk about the portal hypertension days. I am like, oh, I'm jealous.
No,
because I don't think so any of us can have that experience ever, sir.
Really look at it, the incidence of surgery has come down considerably as compared to what it was years ago. We do still operate and do a couple of shunts, but they're much lesser than what they used to be earlier. But that's interesting. That at least we could get to see the vascular surgery part of it. Yeah, actually, I don't know what Tejasvi is asking from Facebook, octreotide in post-operative period. I don't know what exactly she means by that, because octreotide after a Whipple's procedure or LPG, I do not know. Octreotide in post-operative period. Do you use Prathapan in Whipple's procedure?
No, we use selectively when your pancreas is very soft, the duct is very narrow. Actually, I don't know whether it helps or not, but it has two effects. One is it will decrease the secretion of pancreas. Then second thing is it actually produces more ischemia of the pancreatic stem. That is what I feel, because it is a hormone which actually decreases the portal pressure and it actually decreases the vascularity of the pancreatic stem. I think it is a double-edged weapon, and the routine use of octreotide is not recommended.
Not recommended, yeah. I think that's a proper statement. Anyone else for any comments from the audience here?
Prathapan,
yeah, hello.
How often have you ever continued painkillers for chronic pancreatitis patients into the post-operative period? How do you manage their alcohol intake? And how many people have smoking?
No, smoking is the one which produces recurrence of pain, because most of them will stop alcohol, but they will continue to smoke. I think physical dependence of alcohol is better controllable than physical dependence of smoking.
Okay.
I think the pain relief is less, and I will actually scold them because the reason for recurrence of pain is your smoking habit. Don't come with the smoking habits. If you stop smoking, then only you come to my OP. And at least 5 to 8 patients, then it never turn up because they were smoking.
What about the weight gain after coring?
most of the patients who responded to surgery, that means the phrase procedure by pain relief, all of them gain weight. Actually, we can predict the patient preoperatively, which is going to respond. Because patient who has an edematous pancreas, while you do pancreatic surgery, they won't respond because the individual acinar cells are edematous and they are the one who don't respond to your treatment. When their ducts are actually irregularly narrowed and they have the multiple strictures, and even if you do complete pancreatoduodenectomy, they will have recurrence of pain because that is a edematous type of pancreas. Whereas the fibrosis type of patients, where you do surgery and they actually respond. So this is the alcoholic group which has got the edematous type of pancreas. The response to your surgery is poor.
Yeah, Dr. Ishwar, Dr. Ishwar, you want to say something?
Prathapan, wonderful talk. I have one question. There are many pseudoaneurysms you encounter with the chronic pancreatitis. Whenever you are planning for head coring or figures or whatever it is, do you preoperatively embolize them, or what are the special techniques when you operate for them?
If I had preoperative diagnosis of aneurysm, we actually do coiling of the aneurysm.
Yes.
But the problem of doing coiling before surgery is that during surgery, invariably you will damage this area. I had a patient who came to me with 2 failed angioembolization with a large cyst on a background of chronic pancreatitis. Actually, the vessel was not controlled by angioembolization. Emergency, I took for laparotomy, and I did a phrase with ligation of the gastroduodenal artery above and below and control the bleeding. So if you know the exact location of the aneurysm and you are planning surgery, you can actually take those patients unless there is a torrential bleeding or not. So angioembolization prior to your surgery is not recommended, but if your patient develop bleeding in the post phrase scenario, then angioembolization is the method of choice.
In pancreatic hemosuckers, do you have any other special technique to tackle them, or like any other disease?
No, hemosuckers pancreaticus, you need to do angioembolization of the splenic artery prior to your planned surgery. Whereas phrase procedure, actually your tackling of the pancreatic head itself will control that aneurysm. Whereas hemosuckers pancreaticus, actually the splenic artery is producing most of the pseudoaneurysm. If you want to do surgery, you have to do a pancreatosplenectomy. You can't do a phrase procedure or a lateral pancreatotomy. But if you do angioembolization of the splenic artery, then you can very well go ahead with your phrase procedure.
So in that case, we can preserve the spleen?
Yeah, you can preserve the spleen because angioembolization, most of the time you can actually get blood flow to the spleen. But in patients, which I find when there is a splenic artery aneurysm, most of these patients will have atrophied spleen. Their spleen will be very small because the blood flow to the spleen is actually affected. The blood flow to the spleen is actually stealed into the pancreas. So they will have a very small spleen, and when we do angioembolization, nothing will happen to the splenic size. That will remain as smaller. Okay.
Thank you, Prathapan.
Thanks, Prathapan. What will be the next organ for surgical anatomy? Bile duct, gallbladder, or something else?
It will take 2 weeks for me because next 2 weeks I am a little busy. So I will try biliary anatomy. I will try
biliary anatomy next session. When you're ready, we'll go on.
Okay.
Ilango, any comment before we close? Okay. Thank you so much, Prathapan. It's a wonderful lecture, and as Ilango says, it's a lecture worth preserving. We'll do that. Thank you so much. Thanks, everyone.
Thank you.